A very good evening and greetings to one and all. My name is Pooja Gupta and I will be hosting today's webinar on sepsis and septic shock role of nurses. PlasmaGen Biosciences is a biopharmaceutical company enriched with more than a decade of experience in providing world-class plasma-derived products and is based out of Bangalore. We aim to provide immunological medicines worldwide, which provides relief and longevity to the patients. PlasmaGen Biosciences has organized this program under its CSR initiative, Samvedna, Sanchetna, Samvad, for the staff members and students from College of Nursing, Wellness Hospital, Meerut, Maharashtra. On behalf of PlasmaGen Biosciences, I would like to convey my heartfelt gratitude to Dr. Rajendra Kumar for accepting our invitation and presiding over this webinar. Also, we welcome Principal Dr. Sangeeta Satwekar and HOD of Psychiatric Nursing, Mr. Pradeep Ahi, for providing us the opportunity to conduct this program. It is an opportune moment to ponder and discuss about sepsis and septic shock. Now, I would like to introduce our esteemed intensivist, Dr. Rajendra Kumar. He has completed his MBBS and MD in anesthesiology from KS Hegde Medical Academy, Mangalore. Further, he pursued a fellowship program in critical care for Bombay Hospital. His keen interest in intensive care encouraged him to pursue a European diploma in intensive care from Zurich, Switzerland. He is currently working as a consultant at the Department of Critical Care Medicine at Esther RV Hospital, Bangalore. He had been associated with reputed organizations such as Manipal Hospitals, Sparsh Hospitals, SSNMC Bangalore, King Hamid Hospital Bahrain, and Bombay Hospital. He is a member of Karnataka Medical Council, Indian Society of Critical Care Medicine, Indian Society of Anesthesiologists, All India Difficult Airway Association, and a lifetime member of Indian Medical Association. He actively continues to add his expertise to a wide range of research projects. His list of contribution is endless. So now I would like to invite Dr. Rajendra Kumar and request him to address us on today's topic. Over to you, Doctor.
Yeah, able to see the slides?
Yes, sir.
Yeah, many thanks for the kind introduction. My heartfelt gratitude to the faculties of the Vanless Hospital, Meerut, the PlasmaGen Biosciences, for giving me this opportunity to interact and to talk on the sepsis. So we are here to discuss about the most common topic, the most common diagnosis, one of the which we often see in an intensive care unit in a medical ICU. As we know, this month we are, having the World Sepsis Day. It is to make sure that people are aware of the management of sepsis, because for the nursing students, in their future they will have to deal with sepsis patients. If they are if they are planning to work in an intensive care unit, it is better to know. It is a must-know topic wherein they should know the basics of sepsis management. See, definitely nurses play a very important role in the management of sepsis. So if you look at the definition of sepsis, sepsis is a life-threatening organ dysfunction caused by dysregulated host response to infection. So the sepsis has four components. That is, there is an infection. For the infection, there is a host response which is dysregulated and which is causing the organ dysfunction and which is life-threatening. So multiple components, that is, because of the infection, the host response, which is a dysregulated host response, is causing the major organ injury. So hence sepsis, this is a very important definition. I mean, a lot of changes have happened in the sepsis definition, but we have to remember that sepsis definition goes like this. It is a life-threatening organ dysfunction syndrome caused by dysregulated host response to infection. So what is septic shock? Septic shock is sepsis with hypotension despite adequate fluid resuscitation combined with end organ dysfunction. So I will come to septic shock once again. So initially we had this SIRS and severe sepsis, but now they both have been removed. So if you look at the lower side of the slide, so the SIRS response and severe sepsis, they have been removed. The reason is to make it clear that, for example, if there is a patient who is bleeding, because of that his heart rate is on the higher side, his blood pressure is on the lower side, we should not get confused with thinking that it is sepsis. So now coming to the recent definition, there is only sepsis and septic shock. So what is sepsis? Sepsis is life-threatening organ dysfunction caused by dysregulated host response to infection. So there is a suspected or documented infection, and there is increase in SOFA score. So hospital mortality rate is more than 10%. Whereas sepsis with hypotension is called a septic shock. In this, there is a requirement of vasopressors or noradrenaline like substances, inotropes, and in which there is metabolic and circulatory dysfunction. So circulatory dysfunction in the form that the patient is requiring vasopressors, and metabolic dysfunction in the form that the lactate because of the anaerobic metabolism, the lactate is becoming more. And in that condition, as the gradient increases from sepsis to septic shock, the mortality rate increases. So who can develop sepsis? Anybody can develop sepsis, but those who are having immunosuppressed, for example, if they're uncontrolled diabetes, extremes of age, more than 65 years or 60 years, diabetics, uncontrolled diabetes, or who are on immunocompromised state, or multiple injuries, they can easily develop sepsis. Those with indwelling catheters, because of the there is a foreign body, because of the foreign body there is a colonization, because of which there is once again increased chances of infection. So if you look at the causes of sepsis, it can most often we can see as females, we see as urinary tract infections. They develop urinary. So to make it simple, actually, there are two patients. One, a patient with urinary tract infection. He's a patient. He is having only urinary symptoms like fever, burning, micturition. Whereas another patient who is having same complaints like fever, burning, micturition, and in this case the condition has progressed, wherein there is drop in blood pressure, whereas increase in heart rate is there. In such a respiratory rate is more, and which his blood reports are altered. In this case, because of the urine infection, there is manifestation of systemic symptoms. So this is a case. The earlier patient had only a local infection, whereas the second patient is having a localized infection plus systemic manifestation of the disease in that form of drop in blood pressure, increase in heart rate. In this case, where there is metabolic and circulatory dysfunction, that is a case of sepsis. So causes, it can be any simple lung infection in the form of pneumonia can proceed into lung infection, or it can be in the form of abdominal infections, because any simple basically an abdominal appendicitis can lead into sepsis, or urinary tract infection leading into kidney infection, pyelonephritis, or from the gut translocation, or from because of the indwelling catheters, bloodstream infections, which can lead into sepsis. So from the organs, it can be either from the lung, it can be from the heart, it can be from the intestine, it can be from the kidneys, it can be from the liver. Multiple sources can act as sources of infection. So once again, signs and symptoms. If you look at it, it depends upon the organs which have been involved first. But majority of the patients would definitely come with fever, high-grade temperatures or shivering, altered mental status, rapid breathing, tachycardia, or a drop in blood pressure, which further leads to a decrease in urine output, or mottled skin, that is an altered color of the skin, or leading into cold extremities. So once again, we have to look at the symptoms onset. For example, a lung patient can come with symptoms of cough and fever, whereas if urinary tract infection patient can come with burning, micturition symptoms. Whereas a liver patient can come with symptoms suggestive of yellow colored urine, high colored urine, abdominal distension. A kidney patient can come with symptoms of a decrease in urine output. Whereas a meningitis patient, can come with history of fever, headache, altered sensorium. So taking a symptom of the patient, taking a detailed history of the patients becomes important. Detection of sepsis is very important because the earlier we treat, we can prevent the progress of the disease. If it progresses and if there is an established organ dysfunction, the duration of stay in the hospital increases, the overall mortality increases, the cost to the patient also increases. So to prevent the progress of the disease, because here there is an infection. If the infection is not under control, the patient's condition can worsen, which can ultimately lead into the patient worsening from the sepsis into septic shock, which in turn organ dysfunction. Organ dysfunction leads to overall, for example, multiple medical interventions, and hence a prolonged stay in the ICU, which will have the economic burden on the patient, and ultimately, even if the patient survives later, he may have residual deficits. Also, what we say is in antibiotics, as we know, if there is a patient with VT and ventricular fibrillation, definitely shock is the most important thing. Similarly, when there is a heart attack, thrombolysis or angioplasty is most important. Similarly, in sepsis, treating the patient with fluids and antibiotics is very much important. There was a landmark trial which showed that every hour delay in antibiotic led to an increase in mortality rate by 7.6%. So what I'm saying is, if we delay the duration, if we delay giving antibiotics, the mortality rate increases. So if you look at the statistics of sepsis, any hospital which has 10 beds ICU, at least 2 patients would be in sepsis. And what we know is almost 50 to 60 million. Now the number has increased. 50 to 60 million people are affected with sepsis, and it is the most common cause of death in hospitalized patients. In Indian scenario, the incidence is almost 16% in ICU admissions. So if we look at the causes of deaths, for example, prostate cancer, accidents, RTAs, heart failure, the risk of death, the sepsis kills more people than any other medical condition. Such is the importance of sepsis. And also, we definitely, by this time now we know that as the disease progresses from sepsis to septic shock, for example, if the mortality rate with sepsis is around 10%, the mortality rate with septic shock goes up to 50 to 60% each. So identification of sepsis is very important. It can be identified with the help of history. History is like, from which organs these symptoms have started. Next thing is looking at the variables, the vitals, that is heart rate would be elevated. Normally, if it is more than 100, tachycardia would be associated. Later, hypotension would also is a common manifestation. If tachycardia is there, hypotension is there, increased respiratory rate is there, then one would definitely think about sepsis. Coming to blood inflammatory parameters, the WBC count might be elevated more than 11,000. The CRP might be elevated. In case of a bacterial infection, the procalcitonin might be elevated. Organ dysfunction, for example, if in case of lung dysfunction, the oxygenation would be hampered. In case of a kidney-related issue, the decrease in urine output would be there, associated with hyperkalemia, associated with metabolic acidosis, worsening renal functions in the form of urea and creatinine could be associated. And hence, in the APG also, we look at the most important parameter, which is called as lactate. The serum lactate is indicates there is anaerobic metabolism at the cellular level. So lactate could be elevated. So this is the SOFA score, so which indicates the organ dysfunction score. So SOFA score has the 6 parameters. So it's looking at the oxygenation index, the blood parameters, the platelet counts, or the liver parameters, the blood pressure, requirement of inotropes, and the sensorium of the patient, the kidney function tests. So the higher the SOFA scores, the higher is the SOFA is sequential organ function assessment. So if the SOFA score is high, the organ dysfunction is more. If one is finding, if SOFA score is taking time, nowadays we use the QSOFA score. If out of these 3 criteria are present, one can suspect sepsis, because we may see patients with heart rate is high, blood pressure, heart rate is high, blood pressure is high, the blood parameters have not yet come. So one is thinking whether there is because of an infection or because of any other organ dysfunction, whether this is because of heart attack or because of worsening chronic kidney disease. In such a case, one can use a QSOFA score. QSOFA score has the following 3 criteria, that is altered mental status, or the respiratory rate, or the blood pressure. Normally in sepsis, definitely what we know is there is a decrease in blood pressure. Yes, tick 1. So there is also, because of the sepsis or fever, tachycardia is there. So if 2 or more is there, then one can think about or suspect sepsis. If you look at the management of sepsis, initially we had the 3-hour bundle and the 6-hour bundle. 3-hour bundle is basically like things which have to be done. If the patient comes with the suspected sepsis, comes to the hospital, what should the treating doctors do? What should the treating nurses do? What should the treating medical people do? Well, should we wait for the patient's blood reports to come? How should I go ahead? So there are very clear-cut protocols mentioned in this. So now there is a 1-hour bundle. The 3-hour bundle and 6-hour bundles have been combined into a single hour bundle, with the same intention of beginning resuscitation and to start that management immediately. So if the whole 30 minutes lecture, we can combine, we can summarize into this single slide. The hour 1 bundle is the most important. During this time, what we should do. So this slide summarizes my talk. So we have to measure the lactate level. If it is more than 2 millimoles per liter, you have to recheck the lactates. One has to send all the required cultures. For example, if the patient is suspected lung case, send the sputum. If the suspected urinary case, send the urine for cultures. Or blood pressure is lower side, we are suspecting bacteremia, send blood cultures, adequate sample, both for aerobic and anaerobic cultures. If there is a old peripheral central line, we have to use a new site to take the blood cultures. Third, most important, we should administer the broad spectrum antibiotics within the first hour. So what we call in sepsis is hit hard and hit fast. So a good antibiotic, depending upon the clinical condition, has to go. We cannot delay it. We cannot delay the antibiotic saying the blood culture has not been done. But ideally, we should take the blood culture and then give the antibiotics. Depending upon the patient's cardiac condition, depending upon the ejection fraction of the heart, we have to give IV fluids. According to guidelines, we can give fluids up to 30 ml per kg. That is what the bundle recommends, is to start resuscitation and also to start vasopressors. Need not wait for 6 hours. If the blood pressure is on the lower side, start vasopressors. Like the first line, the vasopressor is noradrenaline, with the aim of maintaining a blood pressure more than 65 millimeters of mercury. So once again, it is very, this is the most common thing which we do also. We send an ABG. In the ABG, you get the lactates. We take the blood cultures. We start the antibiotics. And on one way, when you're putting the inserting the IV cannula or the central line, we take the blood culture. And at the same time, once the central line or the external jugular vein is secured, we send for blood cultures also. We start the inotropes also. Okay, the next important thing is source control. For example, if there is a cellulitis of the foot, the sepsis will not get corrected unless there is a source control. So a patient would require two line of therapies, a medical line of therapy or a surgical line of therapy. Definitely medical line of therapy would be your antibiotics, whereas surgical line of therapy would be early debridement. Okay, nurses play a very important role here in this. They will be, they give us clue that there is some abnormal collection, abnormal induration is there, abnormal color is there. In such a way, we come to know by examination that there is some source which has to be drained. Gluteal abscess is there, cellulitis is there. Such source drainage is very much important. And steroids, role of steroids. In case of refractory hypotension, refractory in the terms that in spite of giving adequate IV fluids, if and noradrenaline, high dose of noradrenaline, steroids are recommended to maintain blood pressure. So if you look at the nursing care plan for sepsis, one way to most important is we cannot delay the treatment of sepsis. Most importantly, we have to make sure that things go fast in the treatment of sepsis. We have to remember that delay costs life for the patient. Okay, if you look at the role of nurses, they definitely in the diagnosis, all the required samples are sent, inflammatory, all the required inflammatory parameters are sent, blood investigations are sent, CBC, CRP, liver function test, renal function test are sent. In the initial resuscitation, the fluids are started at 30 ml per kg body weight. Once fluid resuscitation is started, with the antibiotic treatment, the broad spectrum antibiotic therapy is initiated over beta lactams over a period of 1 hour infusion or 2 hours infusion. The antibiotics are started. Source control once at the earliest. Fluid therapy, charting an intake output chart is very much important because if sepsis may be associated with oliguria, so hence importance of fluid balance is of paramount importance. At the bedside, nurse is a person who maintains the target blood pressures. One has to titrate the inotropes in such a way that the mean arterial pressures are maintained more than 65 millimeters of mercury. Steroids in refractory hypotension. Sometimes in case of sepsis with the HB hemoglobin less or than 8, or if we keep early goal directed therapy EGDT in mind, the blood component has to be administered. Not only blood, sepsis might be associated with thrombocytopenia or other coagulopathies. So need for blood transfusion is important. The bedside nurse also takes care of the glucose control. We do not regulate strict blood glucose control. The aim in glycemic control would be less than 180 milligrams per deciliter. So at the same time, there might be requirement of insulin infusions to maintain the adequate glucose control. Bicarbonate therapy might be required in case of pH less than 7.2. In all the stages, the nurse plays a very significant role. So if you look at it, the charting of the vitals, like what is the blood pressure, heart rate, the trend is very much important. The next temperature charting and requirement of antipyretics, paracetamol, in case the patient is febrile. Sometimes pediatric patients, tepid sponging might be required. Always in an ICU, the patients are in a propped up position, head and elevation. This is one of the cheapest methods to prevent aspiration. So positioning of the patient, second hourly change in position is of very much significant. And once again, the titrations of the noradrenaline vasopressors to maintain a blood pressure more than 65 millimeters of mercury. The intake output chart has to be maintained to make sure that we do not go overboard and treat. For example, IV fluid resuscitation might happen in the emergency room, and if there is no proper handover, once again overzealous fluid administration might happen in the ICU. So a proper handover of the details of the patients from the emergency to the ICU, from the ICU to the ward is very much important. Also, sepsis can lead into encephalopathy. There is altered mental stature. So maintaining the GCS is also required. Definitely IV fluid therapy, vasopressors are important. And also the nurse at the bedside also has the important role in educating the patients as well as the relatives about the life-threatening condition called as sepsis. So in such a way, definitely the relatives are anxious who are standing outside because their kith and kin is admitted in the hospital. The relatives also, they find comfortable talking to the staff, so though they would ask the basic information. So it's the duty of the bedside nurse also to educate the patients and the relatives and to give them support during such a crucial time. Thank you.
Thank you so much, Doctor, for such wonderful talk. Now I invite Mr. Pradeep Ahi to moderate the session and request delegates to type their queries in Q&A section.
Hello. Am I audible?
Yes, sir, you are.
Okay. Good evening, Dr. Rajendra Kumar. On behalf of College of Nursing, Honors Hospital, Miraj Medical Center, principal and faculty, as well as all the students, I am grateful to you too much because it was an amazing presentation which included all the aspects regarding sepsis and septic shock, and it was very timely. Secondly, I should not forget PlasmaGen Biosciences team, Ms. Pooja, and all their team for working hard and making this happen. There are a few questions on behalf of the students. There is a typical question asked by an attendee, and it's a direct question like, do you have any experience about neonatal late sepsis and COVID-19?
So the last year we had the COVID-19, the last 2 years we had COVID-19 outbreaks. So I'm into actually adult ICU. So we had seen definitely many COVID-19 patients. So in this sepsis, the most important thing which we monitor is the inflammatory parameters like the CBC, CRP, LDH, ferritin, D dimers. At the same time, we also look at the IL-6 levels. We use definitely in case of oxygen requirement, definitely we use steroids. We definitely use remdesivir along with the anticoagulations, and tocilizumab in few patients in whom the IL-6 were elevated. At the same time, we also use medications like bevacizumab, which prevents the endothelial, the leakage of the capillaries into the lungs. Okay. So yeah, definitely we had a lot of patients with COVID, with sepsis, with ARDS.
Okay. So it was an, I hope the attendee must have got the clear answer about this question.
So only difference would be the fluids would be, we would not give much of a fluids.
Much of a fluid, right.
Yes, we restrict the fluids. And we use steroids in case of COVID sepsis, and in case some conditions, tocilizumab, we use them.
So in short, it's a patient's condition who will hemodynamically assess on hourly basis and his condition, and according to that, the fluids and all the antibiotic courses will be completed, right, sir?
Yes, sir. Yes, sir. Yes, sir. Yes.
Okay. There's one more surgical question that's come up from the attendee. Most common type of surgical site infection from a student. The most common type of surgical site infection.
So surgical site infection, for example, usually if it is a superficial, it will not usually lead into sepsis. Either it could be because of skin and soft tissue infections like cellulitis of the foot, or it could be because of intra-abdominal pathologies like post-operative, for example, after a major surgeries like intestinal pathologies, or peritonitis or basically intestinal surgeries like Whipple's procedures, they can lead into sepsis.
Right. Thank you
So
so much.
intestine,
Yeah.
skin and soft tissue.
Yeah, I'm keeping one question for the last, but this is related again to COVID-19. What is the role or link or a relationship between procalcitonin and COVID-19?
Procalcitonin, according to the sepsis guidelines, are used to de-escalate the antibiotics. If the procalcitonin level is less than 0.5, that means the bacterial infection is coming down. If the trend of procalcitonin is coming down, that means the bacterial infection is coming down. So if less than 0.5, we can de-escalate antibiotics. That is the correct usage of procalcitonin. At the same time, it is extrapolated and it is used in such a way to make sure if procalcitonin is normal, then we can think that this is only purely COVID and there is no superadded bacterial infection.
Right, right. Doc, almost all the questions which our students had, already you have answered it through your presentation, which was a complete package. There's one question which is remain, and I would like you to answer it. Can nurses make a significant impact on the outcomes of the patients suffering from sepsis or septic shock?
See, they are the most important thing actually, because see, the fluid resuscitation is done by the nurses. The antibiotics is given by the nurses. How to give, whether 5 minutes to give, 2 hours to give. See, everything cannot be monitored. In a hospital where like National RV, there is a system established. Once it is done, nurses they manage it by themselves. So nobody is, the doctors are not going to monitor whether the blood pressure MAP is more than 65. The nurses themselves titrate the vasopressors. They give the amount of IV fluids. They give the antibiotics. The ventilators are monitored by the respiratory therapist. So it is a team work. So majority of the contribution is by the nurses only.
Absolutely, absolutely. It's a teamwork. I agree absolutely, because without the health team and everybody's coordination and collaboration, the patients won't be able to be benefited. There's a question: what is your recommendation on nutritional support for post-sepsis syndrome?
So most important is sepsis recommends enteral feeding. That is, as early as possible, start feeding either through the mouth or through the Ray's tube.
Yeah.
So there is no alternative to the natural route. So TPN only, total parenteral nutrition, only if the patient is post-operative, if there is an anastomosis, and if there is a contraindications for enteral feed. Otherwise, the feeding through the mouth, enteral nutrition is the best.
Right, absolutely.
At the same time, we also use albumin. Albumin either in case of shock patients, sepsis with shock, albumin, or after ascitic tap, or in case of liver, we do a lot of transplantations. In post-transplantations, we use albumin. So definitely, colloids we use albumin.
Okay. Let me just jump on to some more questions, few more only. Is there any sepsis-induced immunosuppression greatly increasing now? Because it was seen previously also that there is some kind of immunosuppression after every antibiotic. But how it is increased?
So both are interlinked. For example, patient, it's a dysregulated host response. So sepsis is a dysregulated host response. Right. So the patient is developing sepsis because the immunity is not proper. And post sepsis, once again, because of the sepsis, because of the antibiotics, once again, the patient, after a prolonged stay in the hospital, because of poor nutrition, he will develop a condition called as immunoparalytic state, wherein in spite of so much of the patient becomes dependent on the antibiotics, and it becomes difficult for him to survive without antibiotics. So definitely both can happen.
Okay. There's one question from our vice principal, and he's keen in asking how to exactly identify, is there any new parameters to identify or to differentiate between septic shock and a cardiogenic shock? on the time of arrival of the patient?
Once again, it depends upon the detailed history has to be taken. For example,
Right.
in case of, there could be a localizing signs for infection. Then next, cardiogenic shock can also cause hemodynamic fluctuations.
Absolutely.
Look at the inflammatory parameters also. In case of a cardiac dysfunction, also your WBC count can be elevated. So procalcitonin in such cases helps. But ultimately, sometimes it becomes very difficult to differentiate. It takes time. You have to get all the investigations. You have to get, till we get all the investigation reports. Sometimes it becomes very difficult to differentiate between cardiac problem and a sepsis. I do agree.
Yes, absolutely. Thank you so much. This almost, I think you have already spoke about the SOFA scale and the Q SOFA scale. I think that would be more helpful in identifying and after the discrimination or differentiation between the cardiogenic shock and all. So that is a scale which is newly been implemented almost everywhere in all hospitals. One question from my side, Elliot. You must have seen a lot of patients with cardiogenic shock as well as the septic shock itself. But have you encountered any patients who have landed into complications because of sepsis? The patient was admitted and now he has gone to have a bed sore or a wound itself. Does that intensifies this condition into deterioration, or can it be the same antibiotics which would be just deliberately changed, modified, and it can be covered also with it?
So, in our hospital, in the last 2.5 years, we had only one major bed sore. That too was in a very elderly patient who had COVID. Definitely, in treatment of COVID, we have limitations. Right. Whereas in our medical ICU, we do not have any, we have not seen a single patient with bed sore. That is because of the good nursing team which we have. We make sure that patients who are having, the mobility is hampered, they are definitely in an airbed. And there is a change in position. So in our hospital, we do not, I know other than one case, I barely remember patient having a bed sore in our hospital. So in case of, definitely if patients, there are patients who come from neglected patients or coming from orphanages, they may have bed sores. In such cases, we definitely go for source control. There may be requirement of assistance from a plastic surgeon, early wound debridement, coverage of gram-positive antibiotics would be required, sir.
Absolutely. Thank you so much. We have already seen a lot of questions and you have answered them in a very light mode. There's one question. Will you treat acute infection or severe sepsis? Hypoalbuminemia. I did not actually understood this question. I think acute infection you will treat or severe sepsis. I can even answer this. It's acute infection, and then we will go to severe sepsis because we need to discriminate. But I want your opinion, sir. What would you treat? Acute infection or severe sepsis with hypoalbuminemia?
Definitely if hypoalbuminemia is there and hemodynamically unstable, we definitely give IV albumin. But we have to look at what is the cause of this sepsis. So, for example, if there is a source, acute infection, I'm thinking that somebody is asking about there is a pus collection. So, if there is a pus collection, probably that has to be drained. At the same time, we have time for the patient to be getting shifted to the OT. Meanwhile, we can start the antibiotics also. At the same time, we can start the fluid resuscitation. It has to go hand in hand. We cannot think that the patient will go to the operation theater and then we'll start the IV fluids and then we'll start the fluid resuscitation. So things have to go start. That is why the importance of 1 hour bundle. That is, as soon as the patient comes to the emergency room, we have to take the blood cultures. We have to send get an ABG to check the lactates. Send the blood cultures, all the other required cultures, and start the antibiotics immediately.
Okay. Thank you so much. It was a very nice session, including question and answers. I would just wish to add few things on whatever I've already got from your presentation. In nursing management, I would say what is important is infection control. Because the patient is already having sepsis and certain kind of infection. So nurses play an important role, at least in prevention of nosocomial infections, cross-infection, and contamination, etc. Collaboration, as you said, and we agreed on it, that collaborative team, which is like the main thing to bring out the best outcome in the patient. Managing fever, of course, because high-grade fever, of course, it's just a symptom, but it has to be discriminated and taken care of. Pharmacological therapy, as you spoke, nurses play a very important role, and very importantly, they have to stick to the rights of the patients and the rights of the drug administration. Blood level monitoring, as you said, in cultures, following the daily blood ureas and the ABGs, recording it, checking the differences and reporting it, and then taking actions accordingly. And two things that is continuously going on that should be done, that is assess the physiological status and the mental status of the patient, because both are important for their outcome. That's what I wish. We in our hospital, Wellness Hospital, has a legacy of around 125 years. And right from the student time I'm being here, one thing we usually use in wound care is USOL, that is Edinburgh's Universal Solution of Lime, which is a very typical type of solution used not only in sepsis but also in wound care, and not only sepsis. So it's EUSOL. It's still been used, but of course there are other other parameters and other medications which have come up, like povidone iodine and all those things, mixtures. I would just like to ask you to just look into this. What would be the comparativeness of using this in surgical type? Surgical in the sense septics. So that is one more thing. And this use of alcohol around the wound care while doing sepsis is still contraindicated, or is there any new parameter which has come up for no use alcohol? Because the generative skin after the healing process starts to irritate the skin. That's what is told by a few researchers. So these are a few points which I wanted to add, but I could not add anything else because you have covered everything, right from the definition to the etiological factors, the clinical manifestations, the diagnostic evaluation, like the latest ones, the medication, that is pharmacological management, also the nursing management you covered immensely. I'm right impressed that the doctor is explaining the nursing management in such a varied but a very simple form. It's I'm really kindly warm regards from us as nurses. Thank you so much.
Thank you. Thank you, sir.
That's all from me on the Q&A session. Back to Ms. Pooja Gupta.
Thank you so much, sir, for this wonderful Q&A session. So we are grateful to Dr. Rajendra Kumar for delivering such a pragmatic and informative talk. A special thanks to Dr. Sangeeta Satwekar and Mr. Pradeep Ahi, staff and students from College of Nursing Wellness Hospital, Meerut, Maharashtra, for making this event successful. Also, I request everyone to provide us feedback. The link will be shared via email. With best wishes, now we from PlasmaGen team signing off here. Have a nice day ahead.
Thank you. Thank you
Thank you
so
so
much.
much.
Have a nice day. Thank you. Thank you.
Thank you so much, sir. Thank you so much, doctor.